Hi students, very good morning. Today we are going to talk about periodontal microsurgery. So what exactly is periodontal microsurgery and why it is coming into practice? Basically, periodontal microsurgery is a therapeutic revolution using magnification and microsurgery in periodontal therapy, which has changed the clinical outcome of both non-surgical and surgical success in practice. Nowadays, microsurgery is applied to many of the operations in medical practice to a wide variety of treatment procedures in dental practice. These are the various contents of periodontal microsurgery, which includes introduction, definition and terminologies, rationale for microsurgery, historical background, principles of microsurgery, elements, which includes microsurgical triad, clinical philosophy, magnification systems, head control during microsurgery, microsurgical instruments, indications, and limitations of microsurgery. Periodontal microsurgery is a therapeutic revolution using magnification and microsurgery in periodontal therapy, which has changed the clinical outcome of both non-surgical and surgical success in practice. Periodontal microsurgery, these are the events that spawn a paradigm which begins with a vision. So there has been a tremendous advancement in medical and dental fields to meet the patient's expectations and to achieve much desired therapeutic goals. Microsurgery is an advanced surgical technique in which the normal vision is enhanced through magnification. The use of microsurgical instruments improves a view of root surfaces, permitting more definitive removal of calculus and better smoothness of root. Studies have demonstrated improved vascularization, enhanced mobility of flaps, and hence enhancing the possibility of obtaining primary wound closure, less postoperative discomfort, and providing better aesthetic results. The definition of periodontal microsurgery is defined as a surgery performed under magnification by the microscope. It has also been defined as a modification and refinement of existing surgical techniques using magnification to improve visualization with applications to all specialties. Periodontal microsurgery is also defined as the refinement of basic surgical techniques made possible by the improvement in visual acuity gained with the use of surgical microscope. The rationale of microsurgery is to reduce the amount of trauma to the tissue, minimal manipulation of the tissue, better blood perfusion and healing is faster with minimal scar formation, least possible trauma to the graft, less bleeding with clear vision, healing by primary intention, and patient acceptance. The first microscope was introduced by Anton von Leeuwenhoek in 1694. Then it was further modified by Carl Nylund in 1921. He is called as father of microsurgery. And Apotheker and Jacob first introduced the microscope in dentistry in 1978. Shanilek and Tibbets in 1993 presented a continuing education course on periodontal microsurgery at the annual meeting of American Academy of Periodontology. There are the three important principles of periodontal microsurgery. The first one is the improvement of motor skills, thereby enhancing surgical ability. Emphasis on passive wound closure with exact primary opposition of wound edge and the application of microsurgical instrumentation and suturing to reduce tissue trauma. There are three components for microsurgical triad. The first one is magnification, the second one is illumination, and the third one is instruments. So the purpose of magnification is perseverance of two closely lying objects separately. Illumination is visualization of fine details and instruments to perform microsurgeries. The purpose of microsurgery, the purpose of microsurgery is effective periodontal microsurgery allows the operator to consistently achieve clinical results that were once thought to be unlikely. And it is also a clinically proficient periodontal microsurgeon requires a willingness to adopt new values and ideas. The development of new thought patterns regarding surgical aesthetics is necessary, and attention must be paid to microanatomy, tissue manipulation, and surgical craftsmanship. There are various types of periodontal microsurgical. The first one is loops, the second one is surgical operating microscope, and the third one is three-dimension on screen microsurgery. Before we go into further about loops, there are the principal optical features of loops, which is working distance, working range, convergence angle, field of view, interpupillary distance, viewing angle, and choice of loops. The working distance, it is the linear measurement from the front of lens of the microscope to the surgical surface. The working distance of a periodontal microscope is the space between the objective lens and the surgical site, which is ideally ranges from 200 to 300 millimeters to provide a comfortable working distance for the operator to use instruments. A longer working distance is crucial for performing microsurgery as it gives the surgeon the space and ergonomics needed for precise, controlled movements. The convergence angle of a periodontal microscope refers to the angle at which two ocular lenses are directed inward to focus on a single specific point. There are various types of loops. First, we'll come out what is meant by loops. Loops are the most common form of magnification used in dentistry, which is used in various kinds of fields like endodontics, like in orthodontics and cosmetic dentistry and periodontal surgeries and in pedo. Fundamentally, loops are two monocular microscopes with side-by-side lenses that are angled to focus on an object. Surgical loops for magnification enables the clinician to experience the ergonomic benefit and increase the working distance from viewing the object as well as improved visual acuity. The pattern of convergent lens system is called as capillarian optical system. Three types of capillarian loops commonly used in periodontics are simple loops, compound loops, and prism loops. Capillarian optical system is meant by it is a two convex lenses to create magnified inverted image, which consists of an eyepiece and objective lens, which gathers the light from distant object and forms real inverted image. Prism is added in system, which helps the image to form an upright position. Simple loops are primitive magnifiers with limited capabilities, consisting of pair of single positive side-by-side meniscus lenses. The disadvantage of simple loop is that they are highly subjected to spherical and chromatic aberration, which distorts the image of the object that is being viewed. In spite of its cost advantage, the size and weight limitations make simple loops impractical for magnification beyond 1.5 diameters. The advantage is low cost, the disadvantage is subjected to spherical and chromatic aberration, which ultimately distorts the image and color of the object is being viewed. Their size and weight limits the practical application in dentistry, which beyond magnification range of 1.5 diameters. Each lens has two refracting surfaces, with one occurring as light enters, the other one when light exits. Magnification can be increased with thickness and diameter of the lens. Shorter the depth of field, longer the working distance because of less magnification and image distortion. The compound loops, these are commonly mounted on or the eyeglasses and can be adjusted to clinical needs without excessive increase in size or weight. Compound lenses can be achromatic, which limits the effect of chromatism and spherical aberrations and brings two wavelengths into focus in the same plane, which is an important feature for any magnifying loop used in periodontics. The advantages are better magnification, wider depths of field, longer working distance, and larger field of view. Disadvantages, there is lack of variable magnification, individual light source may be required. Prism loops. These loops produce superior magnification since they contain Schmidt or rooftop prisms. What is meant by Schmidt or rooftop prisms? These are the optical components used in high magnification loops to provide a high quality erect image over a long working distance. By extending the path of light through series of internal reflections, these prisms allow surgeons to maintain proper posture while performing delicate procedures. Prisms are transparent optical elements that use refraction to manipulate a light path. A roof prism is a type of reflecting prism with two surfaces at 90 degrees angle, or a roof that inverts and reverts the image. That means it flips the image. Loop magnification range, it ranges from between 1.5 to 10. In most of the periodontal procedures, prism telescopic loops of 4x magnification, even though lower than the operating surgical microscope, provide an effective combination of magnification, field of view, and depth of focus. The major disadvantage of loops is that the clinician's eyes must converge to view on the operate field, which can result in eye strain, fatigue, and even vision changes when poorly designed loops are used. But loops are less expensive and initially easier to use. Till now, we discussed about the microscopes or the loops. Now coming to the surgical microscope, which is the second component of microscopic loops. The surgical microscope uses the Galilean optical principles. The optical magnification for periodontal surgery ranges between 5 to 12 times. The microscope mountings are available for ceiling, wall mount, or on the floor. Clinicians are not affected by the weight of the instrument or the challenges of the maintaining a stabilized field of vision since they are external to the body. Surgical microscope has both maneuverability and stability. The fiber optic technology has improved the methods of focusing light on specific areas. Documentation of periodontal pathology and procedures of all types and video documentation are also possible. In periodontal loops, the principle followed was Capillarian principle. In surgical microscope, it's Galilean principle. Now, before we go into the detail with the surgical microscope, first we need to know the components of the surgical microscope. The surgical microscope uses coaxial fiber optic illumination. This type of light produces an adjustable, bright, uniformly illuminated, shadow-free circular spot of light that is parallel to the optical viewing axis. It is much more expensive and initially more difficult to use. Now, it consists of a brightness control, a viewing tube or tiltable tube to permit ergonomic treatment, eyepieces with wide-angle optics, objective lens with fixed focal length or varioscope optics, and coaxial illumination, and suspension system, which can be on ceiling, floor, wall, or floor, and magnification changer. The advantages of surgical microscope is greater operator eye discomfort because of the parallel viewing optics of the Galilean system as well as the range of variable magnification, excellent coaxial fiber optic illumination, and countless accessories such as still and video cameras for case documentaries. Disadvantages, it's very expensive equipment. The difference between loops versus operating microscope. Loops, the magnification is between 1.5 to 10x, and the operating microscope is between 2.5 to 20x magnification. It needs additional illumination for magnification of 4 times or greater. Use excellent coaxial fiber optic illumination and does not need any additional light source. Operator eye comfort is less as the eyes must converge to view the image. High comfort as it has parallel binoculars. Initially easy to use, basic training required to use surgical microscope. It is less expensive and operating microscopes are more expensive. Cannot provide variable magnification by loops, and operating microscope has the advantages of providing variable magnifications. The third component of periodontal microsurgery is three-dimensional on-screen microsurgery system. It is used for better visualization of the surgical area through the monitor so that direct viewing through microscope can be avoided and thereby reduces eye strain. The system consists of two single-chip video cameras mounted onto the custom-fit eyepiece adapters, a dual camera controller, and a record image processor, which is called as VCR, for optimal recording and digital monitor synchronization with 120 megahertz shutter glasses. The greatest advantage is that they helps in providing a clear and accurate sense of depth perception. The drawbacks are technique sensitive, high cost, restricted areas of vision, time consuming, and loss of visual reference points. The hand control during surgery. There are three things involved: physiological tremor, hand grip, and hand control. Physiological tremor, these are the finger movements controlled by the long flexor and extensor muscles that move on fingers at relative crude, uh, active finger extension or flexion are likely to be relatively crude. However, when the wrist is stabilized by resting on a flat surface angled in a dorsiflexion position at approximately 20 degrees, more accurately, firm controlled finger movement can be accomplished because of reduction in muscle tremor. In microsurgery, the hand should either directly or indirectly rest on or immovable surfaces, or unwanted movements will occur. Only the fingertip movements, all movements should be efficient and economical and should be made with a unity of effort toward the deliberate motions. There are several factors that can influence a surgeon's physiological tremor, including anxiety, recent exercise, alcohol, smoking, caffeine, heavy meals, hypoglycemia, and medications usage. To avoid these tremors, microsurgeons should also have a relaxed mind, comfortable posture, well supported hand, and stable held on the instruments. The hand grips. Basic hand skill is the United States have been associated with and thought of as an extension of penmanship. With the increased use of keyboards for computers and text messaging on mobile devices, educational curricula no longer stress penmanship. This may play a role in lack of basic hand skills in writing, the acquisition of poor economic habits prior to and during dental education may increase the time it takes for postgraduate residents to become proficient in microsurgery. The most commonly advocated precision grip for microsurgical procedures is the pen grip or internal precision grip, which provides a greater stability in comparison to any other hand grip due to the tripod formed by the fingers while the middle finger holds the instrument. It is the best to start with pen grip until basic manipulations are mastered and more freehand positions are initiated. These are the various kinds of microsurgical instruments. The first one is needle holder, which is called as castrovisor. And these are the various types of castrovisors used in microsurgeries. And the other kind of instruments are retractors, tissue forceps, tooth and non-tooth. The microsurgical instruments, these are circular in cross-section, 15 centimeter in length. The working tips are much smaller, manufactured under magnification to high tolerances. Needle holders and tissue forceps are made of titanium, resistant to distortion, non-magnetized, and are lighter. Shorter instruments with rectangular cross-sectional design, which are not meant for microsurgery. The various types of microsurgical instruments are microsurgical knives, microsurgical scissors, needle holders, needles, sutures, and knots. Microsurgical blade or knives, these have characteristic ability to create clean incisions to prepare the sharp flap margins for healing by primary intention. Using castroviso, microsurgical scalpel incisions are made at 90 degrees angles to the surface. The magnification permits easy identification of ragged wound edges for trimming and freshening. Various types of knives such as crescent, lamellar, blade breaker, sclera, and spoon knife can be used. They offer the dual advantage of extreme sharpness and minimal size. The common characteristics of these knives are their extreme sharpness and small size. This enables precise incisions and maneuvers in small areas. The blade breaker knife has a handle onto which a piece of an ophthalmic razor blade is affixed. This allows for infinite angulations of the blade. This knife is often used in a place of a number 15 blade. The crescent knife, which can be used for intracircular procedures, it is available with one-piece handles or as a removable blade. It can be used in connective tissue graft procedures to obtain the donor graft, to tunnel under the tissue, and to prepare the recipient site. The spoon knife is beveled on one side, allowing the knife to track through the tissue adjacent to bone. It is frequently used in microsurgical procedures to undermine tissue, enhancing the placement of a connective tissue graft. The microsurgical scissors, these are extra fine micro scissors. These are two types, straight and curved. And these scissors, such as the micro venous tissue scissors, are used for removal of small fragments of tissue. Microsurgical needle holders, these are designed to hold the fine needles. They differ in the way they grasp the needle. For example, a grasp with flat surface, if a flat needle is used, the working tips of the needle holder are much smaller and are made up of titanium. The microsurgical needles, there are three distinct elements: the point, body, and the attachment. The point is from the tip of the needle to the maximum cross section of the body of the needle. It is designed to penetrate specific types of tissue. There are several types: reverse cut, taper point or round needle, and blunt point needle. Reverse cut is minimal trauma and early regeneration of tissue. Taper point is minimal tissue cutting and small puncture hole. Taper cut is dense fibrous tissue and periosteum. Blunt point needle dissects through the friable tissue rather than cut through them. The body comprises the slightly more than the middle third of the needle, and it is the major portion of the needle that is grasped by the needle holder during suturing. The size of the body is as close as possible to the diameter of the suture material. The attachment switched end is a method of attaching the needle and suture together in a continuous unit that is convenient to use and minimize tissue trauma. Significant size 16 to 19 millimeters. Majority of the periodontists use reverse cutting needles. So factors considering the selection of suture needles: cord length, needle length, radius, and diameter. The cord length is the straight line distance between the point of a curved needle to the swage end. Needle length is the distance measured along the radius of the needle from the point to end. And the radius is the distance from the center of the circle to the body of the needle if the curvature of the needle were to make a full circle. Diameter, the thickness or gauge of the needle wire. Microsurgical needles. One of the three basic premises of surgery is attention to passive wound closure. The desired result is exact primary opposition of the wound edges. Ideally, the incisions should be almost invisible and closed with precisely placed small sutures with minimal tissue damage and no bleeding. An ideal suture material is sterile, easy to handle, minimally reactive in tissue, resistant to shrinkage in tissues, and capable of holding securely when knotted without fraying or cutting. Ideally, the needle and the suture material should be the same size. Suture size is stated numerically as in 30 or 70. The larger the number of zeros, the smaller the diameter of the sutures. The smaller the size of the suture, the less tensile strength the suture will have depending on the procedure being performed. Most periodontal microsurgical suturing is done with sutures ranging from 60 to 90. Suture bite size should be approximately 1.5 times the tissue thickness to achieve proper wound approximation. The suture choice in microsurgery is a monofilament suture material such as polypropylene or polydioxanone. These materials are bacteriostatic and non-inflammatory. Monofilament materials are preferred as polyfilament threads are characterized by a high capillarity and wicking effect. Suturing techniques are completely different in microsurgery and microsurgery. Geometry of suturing consists of following points. Needle angle of entry and exit of slightly less than 90 degrees. Suture bite size of approximately 1.5 times the tissue thickness. Equal bite sizes on both the sides of the wound and needle passage perpendicular to the wound. Two basic knots employed in microsurgery are the square knot or reef knot and surgeon's knot. The reef knot is composed of two single loops thrown in opposite directions, lies flat when tied well, and is ideal for passive wound closure. As post-surgical edema occurs, the reef knot opens slightly, then becomes self-locking. The surgeon knot is composed of two double loops thrown in opposite directions. The first double throw is less likely to loosen when performing the second throw, making it easier to control tissue apposition. Indications of periodontal microsurgery. It is indicated in scaling and root planing, periodontal flap surgery, mucogingival surgery, ridge augmentation, sinus lift procedures, crown lengthening, root surface conditioning, interdental papilla reconstruction, anterior papilla preservation technique, minimally invasive surgical techniques, and implant surgery. Scaling and root planing. The critical determinant of the success of periodontal therapy is the thoroughness of debridement of the root surface. Accessibility and visibility in deep subgingival pockets, furcation areas, and interdental areas can remarkably be improved using magnifications. It is clear that magnification around 4 to 10 times greater improves the surgeon's ability to create a clean, smooth red surface. It can help to detect islands of biofilm, calculus, or materia alba clinging to the root surface and facilitate removal from areas which were normally not visible to the naked eyes. Periodontal flap surgery. Many authors have proposed the use of microsurgical approach for the treatment of isolated or multiple bone defects. The advantages of microsurgical approach and regenerative therapy relate to improved illumination and magnification of surgical field that permits proper access and debridement of the intrabony defect and increased accuracy and minimal trauma. And it also helps in achieving and maintains the primary wound closure, which minimizes the bacterial colonization and thereby provides more favorable conditions for periodontal regeneration. The advantages of microsurgery are minimal marginal tissue recession and very limited intra and postoperative morbidity and high patient acceptance. Uh, Microsurgery and mucogingival surgery, it is performed to achieve excellent result in terms of both aesthetics and function. and it is fundamental to perform extremely fine and accurate incisions, meticulous suturing to promote stabilization and immobilization of the graft, and precise closure of wound margins. The use of surgical microscope and mucogingival therapy helps for those sites where aesthetics demand complete and perfect coverage. Periodontal microsurgery performed by a trained and skilled surgeon offers an improved outcome of the root coverage procedures. The advantages are increased vascularization of the grafts, relative better percentage of root coverage, significant increase in width and thickness of keratinized tissue, and improved aesthetic outcome and decreased patient morbidity. Microsurgery and sinus lift procedures are the novel applications with a success rate of 97%. The surgical microscope can aid indirect visualization of the sinus membrane and minimizes the risk of perforations. Incorporation of microsurgical techniques for an improvement of altered sensation due to implants encroaching on the inferior alveolar nerve even without unscrewing them has also been reported. Crown lengthening has a comparative studies of crown lengthening with microsurgical methods are limited and seems logical to substantiate the fact that magnification is much better. Microsurgery in root surface conditioning. Root preparation can be done with micro ultrasonic instruments. Smaller the size, which is about zero point 0.2 to zero point 0.6 mm in diameter, and the power settings of 25,000 to more than 40,000 cycles per second. And these instruments allow subgingival treatment in deep pockets with less chances of over instrumentation. Moreover, these instruments have active working sites on all surfaces, which delivers ultrasonically activated lavage in the working area and can be used with minimal water spray. The magnification improves the root surface debridement by enhancing clinician's ability to differentiate the calculus from tooth surface and biofilm to the microscopic level, which reveals morphological contours of both supragingival and subgingival tooth surfaces and accurately procreates working end angles during instrumentation. In interpapillary reconstruction, microsurgical techniques have been developed to replace the lost interdental papilla, which can create phonetic problems, saliva bubbles, and cosmetic deficiencies. This papillary deficiency can be created through iatrogenic surgical removal as part of tissue collapse following extraction, with periodontal pocket elimination surgery, with periodontal bone loss, and with orthodontic separation of overlap teeth. Success in the treatment of black triangle with periodontal microsurgery is a significant leap in the field of perioaesthetics, making it a realistic possibility. Microsurgery and entire papilla preservation technique. This is a recently new microsurgical approach for periodontal regeneration. In this technique, entire interdental tunnel is made through the defect associated papilla by giving a beveled vertical releasing incision in the buccal gingiva of the adjacent interdental space. After granulation tissue removal and root surface debridement, regenerative materials such as bone grafts and enamel matrix derivative are applied. Primary advantage of entire papilla preservation technique is enhanced wound stability and limited premature exposure of regenerative biomaterials. Minimally invasive surgical technique. This was recently introduced in Cotilini and Tuniti, and it is a concept which is designed especially for isolated intrabony defects for periodontal regeneration. It is based on the principle of minimal reflection of very short buccal and lingual flaps with minimal mesiodistal and coronoapical extensions, aiming to expose the coronal edge of the residual bone crest, which includes the defect associated interdental papilla. Modified minimally invasive surgical technique has been proposed by Cotellini and Toniti in 2009 in combination with enamel matrix derivative. The overall idea of modified minimally invasive surgical technique is to provide a small interdental access to the defect only from the buccal side, following which the supracrustal interdental tissue is dissected from the granulation tissue by means of a mini plate and regenerative material of choice applied. It is a passive closure by internal mattress sutures is preferred. Implant surgery. The surgical microscope is a very valuable tool in implant dentistry. Different stages of implant treatment, ranging from implant placement to implant recovery and peri-implantitis management, is accomplished with more precision under magnification. Microscope may be a valuable tool in visualizing the last threads of the implant for subcrystal placement, implant recovery with minimal trauma to adjacent tissues, management of peri-implantitis, visualization of the sinus membrane during sinus lift procedures, and minimizing the risk of perforations or tears. The drawbacks of microsurgery are there are few shortcomings of this and needs to be reconsidered prior its application. It is much more demanding and technique sensitive. The cost incurred to establish a microsurgical setup is also high. Magnification systems used also pose some difficulties, including restricted area of vision, loss of depth of field as magnification increases, and loss of visual reference points. An experienced team approach mandates microsurgery and is time consuming to develop. Physiological tremors, control for finer movements intraoperatively, and a steep learning curve are required for clinical proficiency. The recent advances in microscopes are Zeiss OPMI Pro Ergo, mechanical optical rotating assembly interface, periodontal endoscope, videoscope, infrared 800. The aesthetic preservation and improvement have become an integral part of today's periodontal treatment. It helps in evaluation of periodontal aesthetic procedures and drives largely the patient's increased awareness and desire for aesthetically pleasing smiles. Patients are demanding a youthful, attractive smile that includes healthy gingiva with ideal contours and texture. Periodontal microsurgery is defined a must for perio aesthetics. The improved visual acuity provided by magnification opens a whole new world for those who make effort and take time to become proficient in microsurgical principles and procedures. The promising periodontal microsurgery will provide new possibilities to improve the therapeutic results for a variety of periodontal surgeries. So with this, we conclude the topic periodontal microsurgery.